Your patients in operating rooms can't afford for your steam sterilizer to go down. A lot is dependent on your steam sterilizer. You need pass-fail results quickly and definitively, without guesswork, while improving workflow. The 3M Attest eBowie DIC test system revolutionizes sterilizer testing and delivers automated results. The same testing method you've always trusted, now digital. Learn more at go.solventum.com/EBD-APIC. 3M Healthcare is now Solventum.
You are listening to the 5-Second Rule podcast presented by APIC, the Association for Professionals in Infection Control and Epidemiology. This podcast is produced by the APIC Communications Committee and is intended to be a conversation between our hosts and professionals practicing in the infection prevention and control industry. You will learn and be entertained, but most of all, we hope you will be inspired by our community and the work of our peers. And now, on to the show.
Welcome to the 5-Second Rule podcast. We are your hosts. I am Kelly Holmes, and my preferred pronouns are she, her.
And I'm Lerenza Howard, and my preferred pronouns are also she, her. Happy holidays, Kelly.
Happy holidays, Lerenza. I'm excited for our show today. We're diving into the world of sterile processing today. And joining us in that discussion is Rebecca Alvino. Rebecca Taylor Alvino is a board-certified infection preventionist and perioperative nurse. She serves as the System Director of Sterile Processing at UCSF Health in San Francisco. She's active with APIC, currently serving as the President-elect for the San Francisco Bay Area chapter, and most recently co-authoring the recently released update to the APIC Text online chapter, Reprocessing Single-Use Devices. Welcome, Rebecca.
Thanks, Kelly. Thank you for Lerenza for having me, and happy holidays to everybody.
Happy holidays to you as well. So, kicking off our episode, tell us a little bit about yourself and your journey and how you became a leader in sterile processing.
Sure. So, I was in nursing school back in August of 2003 at St. Joe's College of Nursing in Syracuse. And I was the one and only person who, when we were going around doing our introductory icebreaker, that said, when I grow up, I want to go into infection prevention. And everybody just sort of turned heads and was like, nerd, what? But that's what I wanted to do. I had come from public health, and this is what I fell in love with. The idea of doing disease investigation, that's really what drew me into infection control. And it was when I finally had the opportunity to realize that dream in July 2013 that I realized that infection control and prevention is so much more than just doing disease investigation. It is such a broad field, and it gives you an opportunity to learn a lot about a lot of things. Also gives you the opportunity to specialize, which is sort of what I've done in my career. I've been in healthcare now almost 20 years as a nurse, and I've really developed my niche and focus within surgical infection prevention and more specifically within disinfection sterilization.
That's amazing, Rebecca. And of course, sterile processing is something that I'm absolutely interested in as an infection preventionist because, of course, prior to coming into this field, I did not realize that this was a department that even existed in healthcare, to be quite honest with you. But one thing before I go into my question, I am curious about your co-authoring the APIC text. So tell us about that experience.
Yeah, it's a challenge, most definitely, to take on any sort of publication, right? And I'm fortunate to have within my team of sterile processing experts at UCSF, one of probably the nation's leading subject matter experts in disinfection sterilization by the name of Gene Ricapito. And we've just been able to forge this incredible working relationship over the 10 years that he's been at UCSF. And we took on this chapter when really there wasn't anybody else raising their hand. And this is something that I wanted to learn more about. It's not something that is typically done in a lot of healthcare facilities, at least in the US, it is a myriad of regulatory requirements. And even globally, WHO and others don't advise for healthcare facilities to take this on. Certainly, there's a big sustainability driver globally for healthcare. Healthcare is one of the main drivers of waste in the world, really. I mean, especially in operating rooms. Operating rooms are real big drivers of waste production in healthcare. And so there's a big interest in taking on more sustainable ways of delivering healthcare, but it can be really tempting, especially from a cost savings perspective, to try to reprocess single-use devices. And we saw this going on during the pandemic when there were global supply chain shortages. There's definitely, I would say, do not use the pandemic as your rationale for saying, oh, I need to reprocess this single-use device and I could do it during the pandemic. So much has changed since the onset of the pandemic, and diving into the research needed for this chapter was eye-opening about how much regulation is involved. And I think it's really important for infection preventionists and others to realize that just because it doesn't get reprocessed at your own facility doesn't mean you don't have a vested interest in what's happening to produce that reprocessed single-use device. And hopefully this chapter provides not just that lengthy regulatory background, but also what can IPs do to think about how to address reprocessing single-use devices and the safety mechanisms, and what are the realities that you have to consider if you suspect a single-use device may be the culprit to an infection or a rash of infections.
Oh, wow.
Absolutely.
That is, yeah,
And of course,
very fascinating.
yeah. And of course, if you're an IP that has yet to delve into the world of sterile processing, I would definitely recommend for you to take that leap and that deep dive, just like Rebecca did. But I want to know, Rebecca, what are some of the challenges that you are facing in the sterile processing department, particularly related to infection control?
Well, for me, moving from infection prevention and having that technical expertise and becoming a sterile processing leader, I knew that my biggest learning curve was going to be learning the operations of sterile processing. And I will say I've been able to overcome a lot of that learning curve, but I am still continuing to learn. The biggest thing for me was going into one of my SPDs and finding damage to the wall, or something that had to be fixed by our facilities teams, and saying, oh, hey, we got go ahead and put in a work order and get that wall painted. Oh, wait, that's my responsibility now, right? Because now I'm the leader, and now I'm responsible for making sure that work is actually getting done. So that's one of the things for me that has been one of my biggest challenges. One of the other challenges, I think, for infection preventionists is, Lerenza, like you said before, it's do you know that it exists? I mean, there's even people that have worked in healthcare for a long time that didn't realize that someplace those sterile instruments came from. And these are the people and these are the facilities that do it. And so in infection prevention, even the most seasoned clinician that's in infection prevention, if you've never stepped into the world of sterile processing, it's highly regulated. It can be intimidating. And it's just something you have to be willing to put your arms around and get used to. For me, even as an operating room nurse, I knew enough about sterile processing and the rules around it, but it wasn't until there was a pretty significant exposure event that I got thrown into this world. And that's really what became my why, was that exposure event and learning everything that I could about sterile processing to become an advocate and a partner for those teams.
That's fantastic, Rebecca. And I, echo what both you and Lerenza have mentioned about, an infection preventionist who might not have a nursing background, who's coming into the role of infection prevention. It is very intimidating to walk down to sterile processing. And I think the first time that I went through, it was so overwhelming. I don't know that I really even absorbed any of the information that they were talking about. It took probably, 3 times to go through and have someone walk through with me. Here's the sterilizers. Here are the biological indicators. Here are the, measures that we track, and here is why. So you're right. It is a very big topic, but The more you go, I think the more you become familiar with the questions to ask and what you should find when you go down there. So in line with that, are there any key performance indicators or KPIs that SBD track and monitor? And, how are IPs involved in that? What should we be asking for and looking for? And then, I guess this is a loaded question. So my other part of that would be, I know that hospitals do have that surgical instrument tracking software, or that is out there and available for some hospitals, but some hospitals do not have it yet. So, what are some ways that we can meet these key performance indicators without some kind of tracking software?
Absolutely. So one of the KPIs that most infection preventionists will recognize is immediate use steam sterilization, or IUSS. That is one that we have to report for any regulatory or accreditation survey that we may encounter, whether it's a survey for accreditation or if it's a complaint survey. That's something you just need to have on the ready. There's ideals of where you should be in terms of your IUSS rate, really less than 1%. I'm pleased to say that our facility, among my teams, we have 0 IUSS, and that's because we do utilize expedited reprocessing through an FDA validated system, but we track it very similarly to IUSS. So for us, that's really one of the primary KPIs that every infection preventionist should be aware of. Other KPIs that my team and I look at are things like throughput times, and that is not something that is nationally benchmarked, right? And so a throughput time would be from the time that your soiled instruments arrive into your decontamination area, and then how long does it take to get through the entire process? When you look at that throughput time from end to end, that can really be insightful about how much time it takes for something to move through your system and to start to identify where there may be bottlenecks or challenges. So again, considering that there's no national benchmarks, this is where it's important to really, as best you can, if you've got inventory management systems in place, what do your averages look like? You can't just take a single snapshot in time and say, oh, okay, it takes 4 hours for something to get through the process, right? You have to look over time and say, okay, it's taking 4 hours to get through the process, except for these particular types of sets, it's taking longer to get through the process. Now, why is it taking longer for these particular sets to get through the process, right? Or, hey, why is it taking so long for things to get through our decontamination area, right? It may give you some insight as to, does your decontamination area have enough resources, sinks, washers, ultrasonics, to get through the process effectively and quickly, because cleaning is really the crux of the entire disinfection sterilization process. Without adequate cleaning, there really is not disinfection or sterilization to be had. So if you're finding that it's taking a long time for things to move through your decontamination area, that's a major bottleneck, and that can contribute to instrument damage, to biofilm formation. There's a lot of things that can come about from that. So throughput time is another KPI I suggest IPs just start to ask your sterile processing departments, do you have the means of tracking this? Are you tracking this? And what do those data look like?
Oh, that's so helpful, Rebecca, because I think it does go hand in hand with what you mentioned about immediate use sterilization, or the IUSS. So if a place does not have the instrument tracking system, they might have a higher IUSS rate, and they might not really understand why, but this could be a deeper question then to ask. Okay, so we have a high IUSS rate, let's look at our throughput numbers and see maybe where these bottlenecks are occurring, and it could then... Am I correct in saying that it could then possibly reduce IUSS rates?
It's entirely possible, but at least the more KPIs you have to look at the process, to look at the people, to look at the physical plant, the data are going to be able to give you some indications. If you have a high IUSS rate and you're finding it's taking a long time for things to get through your decontamination area, for example, there may be this enticement to cut corners. And that may be where, oh, okay, this set took a really long time to get through the decontamination area for whatever reason. And that's where it's incumbent upon the IP to figure out what those reasons are that may be leading to that high IUSS rate. IUSS, one thing that I know sterile processing partners will contend with is the use of IUSS or expedited reprocessing as an inventory strategy, right? For example, we're doing 10 total hip arthroplasties today, but we only have 3 total hip sets. Well, we've got to turn those over, and we're going to meet that clinical need by utilizing IUSS. Those are 90-day SSI categories, and that's not really a corner that you want to cut when you're talking about cases and surgeries that have such high morbidity associated with them should somebody end up with a surgical site infection. Those revisions, those removals of implants can be devastating to patients, right? And if you can trace it back, it may not be your culprit, your smoking gun per se, but it may be a contributing factor to why you got some infections that are happening. If you're finding corners are being cut, look to the data. And if your sterile processing departments aren't generating the data, find out why. Why are they not generating the data? Do they not have the systems in place? If they don't have the systems in place, how can you help them to generate the data? How can you partner with them to get the systems needed to help start looking at, is it a process related issue? Is it a human factors issue? Is it a physical plant issue? The data, it is such a data rich environment, sterile processing departments. Leverage it as much as you can.
Wow, amazing, Rebecca. As you noted, and I would think that would be a call of action to, IPs that are experiencing those high IUSS rates, maybe having that presentation with the respective stakeholders just to review that information and drawing that correlation. Of course, not a causation, but a correlation possibly with an increase in SSI events. But then going into a different area of our conversation, let's talk about AI. So, of course, artificial intelligence is a buzz among many different arenas, including in infection prevention. I know APIC, they recently, a few months ago, had the APIC AI Summit to review the impact that AI may have on our profession. But from your purview, what are some of the new technologies or advancements that you're particularly excited about?
When you talk about AI and sterile processing, one of the advancements I'm most excited about right now is the use of AI with borescope inspections. So right now there are platforms available in the marketplace that leverage artificial intelligence to help borescope users identify what are the defects they may be seeing in flexible endoscopes. And I think perhaps coming down the pipeline, even with like arthroscopic shavers, that technology is going to be able to be leveraged to help you say more definitively, okay, I'm running this borescope, I see this defect, now what is it? And help you to articulate what to do with that information. I've been saying for a long time, borescopes are excellent, but they're not plug and play technology. You have to know what you're looking at, and you have to know what it means, and you have to realize what the implications are clinically. Because remember, there is a patient on the other side that is not just relying on us providing a safe patient-ready device, but also to get that procedure that they need. So it's really important to make sure that whatever technology you're bringing, including these AI-based platforms, that you're letting your clinical end users know, hey, this is what's happening, and these are the steps that we need to be prepared for should we find that all of a sudden we're leveraging this AI-based platform to drive our borescope inspections, and you start finding more issues than you may have realized truly existed in some of your flexible endoscopes, right? So making sure that they've got a mechanism to get safe loaned inventory in place should they have to take things out of service. But again, it's there as an adjunct, it's there as a tool. And I'm really excited about it because especially when you look at some of these moisture droplets that you may find retained inside of a lumen, is it water? Is it simethicone? Is it soil? And hope, as AI continues to build and it gets more refined, it's going to get better in being able to tell you more definitively what that defect is. But any AI, like anything, garbage in, garbage out. If you don't have good data to feed into that system, you may end up with bigger issues. I don't think that's going to be the case with this particular platform, but it's just something always to keep in the back of your mind. You've got to have good data going into your AI system to help further refine its efficacy.
Absolutely. And making sure that the recommendations that are generated from that AI software are, make sense, that are logical. But I know that has been really helpful, the borescope, in our sterile processing department, particularly, as you were saying, with the arthroscopic shavers. And all of a sudden you're looking inside these lumen devices and you might see rust. So what does that mean for our water quality? What do we need to do? So yeah, it's very exciting that AI is going to hopefully help us solve those puzzle pieces. So, kind of circling back to IUSS, could you please explain to our listeners what is meant by the term IUSS? I think when I first started, we all called it flashing. And as a new IP, I was like, what are they talking about? Like, what makes it a flash cycle versus why is this a bad thing? And so, but of course, it's been around a long time. It can be appropriate for practice. So could you kind of just debunk all that for us? Tell us about IUSS and, when it's okay to see it and when it's not.
Yeah, I remember as an OR nurse back in 2005 when I was first starting to learn and going into the substerile rooms and seeing these autoclaves on the wall with these big submarine doors on them. And it was like, oh, if something hits the ground, you take it over to the sink in here, you just rinse it off, and then you go ahead and you throw it into this autoclave and you push either 1 or 2 for whatever cycle. There wasn't a lot of explanation. It was sort of like, yeah, take a patient sticker, put it here, explain why on this log sheet, like which cycle you're running, the date and the time, and did it pass, and here's the tape, and here's how you look at pass. It was sort of something like, yeah, this is a necessary evil that you have to employ, but it wasn't sold as something that was really highly regulated. Whereas now, I mean, really more and more operating rooms and sterile processing departments are requiring that if you run IUSS, that your sterile processing teams perform that work because it's so regulated. It's one of those low-hanging fruit for surveyors to say, look, your cycles don't line up, your information's incomplete. It can be a really big vulnerability. And again, IUSS, immediate use steam sterilization, it's not an inventory strategy. It's there for when something happens that was not expected, right? So for example, I always like to joke, if something that's sort of one of a kind hits the ground, I'm like, did they turn the gravity down in the room? More instruments are hitting the ground than with other surgeons you would work with, right? But the thing is, you should have backups really. Backup inventory should be available as frequently as possible, ready to go, sterile, so you can avoid the IUSS.
Yes. And so, the defining factor of IUSS, is it the fact that it's an abbreviated drying cycle? Is that what we should look for as an IP when we're, looking at the ticker tape, I guess is what I always call it, for lack of a better word, that comes out of the sterilizer? And, you're looking at that exhaust time. And if there is no exhaust time, that's a huge clue that it was IUSS.
Right, exactly. Okay. So IUSS usually is programmed only for a couple of exposure cycles. 4 minutes or 10 minutes has always been my experience. And there's not a dry time, right? You have the machine conditioning, you have the exposure, and then everything comes out essentially wet. And some people may ask, well, if it's wet, then how is it sterile? Well, it's because it didn't dry. It's IUSS. So that's part of the reason why we shouldn't be utilizing it as an inventory strategy. Because again, it's coming out hot, it's coming out wet, it's coming out, even with those factors in place, it can be a risk, especially if it has to be immediately used at the surgical field. You don't want something hot and wet traveling through the air, if you will, catching whatever's on the air current, and they have to cool it down with some sort of irrigant. But here's the other thing to remember, that inside your sterile processing departments, especially if you do not have autoclaves in substeriles or adjacent to your ORs, you may have full format sterilizers in your SPDs that have IUSS cycles programmed onto them. So I have been in some of my presentations emphasizing to IPs, as part of your rounds, when you're learning about your departments, ask, do you have IUSS cycles programmed into your machines? Don't just assume it happens in the operating rooms or at the point of use. It can also be programmed into those machines where they don't have those dry cycles. And not everything is validated for IUSS or expedited reprocessing. For example, taking a rigid telescope and putting it into an IUSS or an expedited reprocessing cycle, probably going to ruin that scope, right? So everything has to be validated for expedited reprocessing or IUSS.
Absolutely. And your recommendation, Rebecca, just on that same topic, is that SPD departments have a log or registry of those instruments that are validated for IUSS cycles.
It would be definitely, or should definitely be, in the IFUs for the instrumentation that's being reprocessed through your SPD.
Absolutely. So I know, as it was previously noted that SPD could be a very intimidating workflow within some IP's workflow. I should say, if they're responsible for this department or if they're a lone IP. So, some people may find it intimidating to even start, rounding in this area, or feeling comfortable and confident in asking the stakeholders within the department questions about their processes and workflows beyond just, there's a hole in the wall, or there's some, things such as that, superficial things such as that, and really drilling down and getting to the nitty gritty of the workflow within this department. Rebecca, what advice would you share to IPs that are maybe new to the field of IP, or maybe new to SPD? What advice would you share with them in starting off their ventures within the SPD department? And also, what strategies should they take to assess the competency of SPD staff? Because I know it can, come off as intimidating trying to assess the competency of SPD staff when you yourself are also trying to learn their workflows and policies.
Yeah, absolutely. And I think first and foremost, you just have to be persistent and let them know that you're a partner. Come in with humility and just use your resources. Use your APIC text if you've got access to it. If you've got access to the AAMI standards, just start to get familiar with them, and definitely start looking at the policies and procedures for your sterile processing department. When you go in, just go in again with an air of humility. You're there to learn, ask questions, and let them know that you're learning. I think showing a little bit of vulnerability and letting people know when you're trying to learn is going to get you inroads, but also always just stay vigilant. Don't allow somebody to mislead you into believing that something they're doing that's wrong is correct because they don't want to deal with you, right? So always just, if you got the hairs on the back of your neck, or, something just seems awry when you go in there and you see something that just seems really bizarre, then make a note of it and just ask about it and perhaps circle back to it later. I definitely say, if you're going into your sterile processing department, you wear skirts, you wear kilts, you wear dresses, and you think you're going to put on a bunny suit, this is not the time to do that. I say, put on the scrubs and be the example that you want to see among your sterile processing professionals. And I say that because whenever I've been dressed, I purposely sometimes try to get dressed not in scrubs so it keeps me out of the department, and I just let people work without me over their necks. But sometimes I have to put on a bunny suit and go into the department for something right quick. I'll be wearing a skirt. I feel like every time I take a step, my skirt starts to ride up, and I have a strict no policy. And I'm always paranoid about that, right? So if you're going into an OR or any place and you're wearing a bunny suit, that's not the day to wear your skirt, dress, or kilt, I assure you. But wear your scrubs, wear the appropriate hair covering that's defined in the policy. This is not the time, if you're going to start inspecting instruments and taking a look for quality, to wear jewelry. Be the example you want to see with your sterile processing partners. For assessing competencies, again, this is where approach it first with a little bit of humility. You're going to get a sense of what seems obviously wrong and what seems obviously right. If you don't know what the answer to a particular question may be, for example, if you see somebody that's doing decontamination work, you see them working under the surface of the water when they're decontaminating at the sinks, that's correct. But if you see them working with brushes that are bent and they're gross and they just look like they're shredded or in really bad condition, well, ask, how often are they supposed to change them? And pick some new ones up off the shelves if they've got them, and look, are they single use? Are they reusable? Just start asking questions, and again, approach it with a purpose of humility. I think as IPs, we work really hard to remove ourselves from the perception of being the police, of hiding behind clipboards and certainly trying to be punitive. And sterile processing is very much the same way. They don't want to be addressed in a way that seems punitive or pointed. a lot of sterile processing departments, they just need good advocacy and partners. They need resources often. Sterile processing departments, quite frankly, are a cost center. It's a cost of doing business, but it's a cost that a lot of healthcare facilities have a desire to keep low. And this is not, again, the area that you want to cut corners with. So there's ways to be cost effective, but you can't do it at the expense of patient safety. You can't do it at the expense of regulatory accreditation. So it really requires IPs to approach sterile processing, even if you don't know a lot about it. Start reading, start learning. I encourage people to reach out to me whenever I give presentations. I say, feel free to reach out to me. I am more than happy to help you however I can, if I can. And if not, I bet you I know somebody who can, right? Because this is just way too important work for a hospital, for an ambulatory surgery center, for a dental clinic, for an outpatient clinic. The work is way too important and it touches the patients way too critically to have corners cut.
Oh, thank you for that,
Yeah.
Rebecca. I think you make a really, really good point about going in with the humility. I think that infection preventionists, we have a lot of pressure that we're subject matter experts, in every form of infection control in all parts of the facility. But, hearing you say, hey, it's okay. You can be a subject matter expert in infection control and, having an emerging amount of knowledge within sterile processing, but to arm yourself with as much knowledge as you can by reading the APIC text, finding some webinars, before you go could help you ask some of those important questions and help you recognize what's going on, and have that conversation honestly, like, oh, tell me your process for this, and what's the dilution for that? How do you know how many gallons are in the sink? All of those things. Are there any? So, as part of the updated Joint Commission standards, they say that the IP is responsible for competency-based training and education of hospital staff on infection control policies and procedures and their application. So within sterile processing, do you have a checklist for staff that you do upon hire? Is that something we should be asking for when we do our rounds?
Yeah, I think it's something that you definitely want to ask, especially if you're seeing, just like with your Joint Commission or DMV or your regulatory surveys, they go in, they assess somebody, they'll ask questions, and then they want to see their HR file because, to your point, Kelly, they want to know, what is their competency? How has this been assessed? When was this last assessed? We don't want to make assumptions that simply because somebody has 4 certifications from one of the certifying boards that they know what to do, because your practices may be such that you require certification, but your practices are so nuanced or refined to meet your needs within the bounds of evidence-based practice that simply having that certification isn't enough. You've got to be able to demonstrate competency. So certainly upon hire, having that checklist, do you know how to do these particular things? But then ask the next questions. Well, how frequently are you reassessing? Just like in nursing or any other profession, you tend to find ways to cut, maybe not cut the corner, but curve it a little bit, right? Just because it's a little bit more efficient, or you have somewhere along the line said, well, do I really need to do that? Because when I do it this way, I don't see a difference, right? But it's because they may not see a difference. They're not far enough down the stream to realize the difference, right? Until or unless something consequential happens. So I think it's important to then ask as an IP, okay, how often are you assessing competency? Are you assessing competency every time a new flexible endoscope comes within, for example? If you have an endoscopy department that your SPD is supporting and they've now switched manufacturers for their GI scopes, have new competencies been performed? Because the IFUs may be similar, but they're not exactly the same. And perhaps the processes are just nuanced and different enough that it requires a new competency. So I think those are some fair questions to ask. How often are you assessing? How are you assessing? Is it verbal? Is it return demonstration? Is it a combination of the two? Is there like a dedicated skills day, or is it on a rolling basis? And then when you have new equipment coming in or you have new devices coming in, are you reassessing competency for your teams?
That's very helpful. And, something that Lerenza and I had talked about earlier was talking about infection preventionists becoming certified in SPD. And, is there a trend towards that? Do you recommend it? What are your thoughts?
So I definitely see a trend towards IPs becoming certified in sterile processing. And I will say, and I know it will send some shockwaves through, I find it to be a double-edged sword. I think it's great that infection preventionists want to learn and dive into the world of sterile processing. There are two certifying boards. There's CBSPD and there's HSPA. CBSPD is a test-based certification body, whereas HSPA has some practice requirements associated with their certification qualification. So there may be some, and I say this as we've had some labor actions, there may be some expectations that if you're certified, that you may be asked to step in and perform the work, because there's that assumption that, well, if you're certified, then you know how to do this work, right? But certifications are a demonstration of a minimum knowledge, right? There's a difference between having the knowledge and having the capability of executing the work. And I acknowledge that with my team all the time, where I say, you guys, I know how your job is done, but when it comes to actually wrapping a tray, they are the experts. I am terrible at wrapping it because it's been a really long time since I've had to do it. And so that is not something I would feel comfortable necessarily stepping in to do expediently, right? So IPs wanting to do this, I think it's fine so long as you go about it the right way, right? Meaning that you've done the hours necessary if you're pursuing that experience required certification, but also realizing that you still need to exercise that humility, because there's a big difference between demonstrating you've got the minimum knowledge and demonstrating that you can actually execute the work.
Mm-hmm. Absolutely, Rebecca. And thank you for your insights on that. I know that one of the things that was noted, related to your last point of practicing that humility, I think that one of the things that's integral, especially with bolstering our relationship with our strategic partners, including SPD, is, as you and Kelly noted, asking those open-ended questions and actively listening, and then transitioning our partnerships, if necessary, from more so of a partner versus the IP police.
Yeah, I completely agree, because again, this is a department that seemingly is often overlooked. I will say that sterile processing is getting a lot more attention. There are a lot of advocates out there in the social media space and elsewhere, including APIC, that are really becoming big proponents for sterile processing and the importance that it serves in the provision of healthcare. As I tell my team, SPD, it's sterile processing department, but you're serving patients daily. The work they do, it touches patients in such a way that is often unsung and often isn't recognized as important until there's a problem, but that's way too late. These are professionals that need to be recognized every other time that they're doing a good job, because when you hear that, a surgery went well without any issues, no contamination, that's the time to recognize those sterile processing professionals. And I think IPs really have the ability to be good partners and advocates, right? Especially now. As sterile processing professionals, I think there's a big momentum, and IPs can continue that momentum for them to get the attention that they deserve.
Absolutely, Rebecca. So that's a great way for us to end the episode, and just highlighting and really sending that kudos to the SPD partners and the stakeholders, including you, Rebecca, that are absolutely integral to preventing infections within our healthcare facilities. So thank you for all that you do and all the SPD professionals do within our healthcare space.
Yes, I echo what Lerenza said, and I'm not ready to let you go, Rebecca. I want to keep talking for at least another hour because I have so many more questions. It was so informative and educational. Thank you so much for your time.
Thank you for having me today.
Thanks for listening to APIC's 5-Second Rule Show. We want to hear from you. Visit us at www.5secondruleshow.org. That's with the number 5, where you can contribute to the conversation. Make sure you subscribe and rate us wherever you listen to your podcasts. We're so appreciative of the hard work each of you do every day to make a safer world through infection prevention. Remember, IP stands for Important Person. You are awesome. Stay safe, and we'll see you next time.